Assalamu alaikum jami'an. Good evening, everyone. Welcome to our Young Leader Forum, Season 5. Our theme for tonight is endocrine emergencies. We're going to have tonight three endocrine emergency related talks, and the fourth talk will be a skill related talk. That will be followed by the Q&A session, and then finally we'll be having the Serbia sponsored talk. So welcome everybody to our presentation tonight. Our Young Leader Forum Symposium is a CME accredited by Dubai Health Authority. And following the webinar, you will be receiving a survey. Kindly fill it, and following that, within 4 weeks, you should be receiving your CME certificate. Our webinar is live streaming on EDS YouTube channel. And also it will be on the EDS on demand on the EDS website. Kindly, for any questions, you can post it in the Q&A questions, and you can mention the name of the speakers. For any technical support, our live chat support is available online. So without any further delay, we will be starting with our first presenter, Dr. Raya Al-Mazrou'i. Dr. Raya will present us on endocrine hypertension. Dr. Raya is a consultant endocrine working at Tawam Hospital. She's as well as an adjunct assistant professor at U University. She finished her fellowship training in diabetes and endocrine at Imperial College in UK. She's as well a graduate from Harvard Medical School research training. And she's involved in many academic teaching for both undergraduate and postgraduates. Dr. Raya, the floor is yours. Kindly, you can unmute yourself and start your talk.
Thank you so much, Dr. Abdou. Thanks for giving me the chance to participate in today's event. We have only 20 minutes, so hopefully we'll try to be focused and brief. During this presentation, I'll try to cover the just a minute. I'll try just to cover causes of endocrine causes of hypertension, and we'll start our presentation with introduction. Then we'll go over causes of endocrine hypertension, and we'll explore how to approach causes of hypertension, secondary hypertension related to endocrinopathy through cases, and then we will conclude. So to start with, in 2020 International Society Guidelines for Hypertension, there was a section about secondary hypertension. And they do recommend screening for secondary hypertension in selected patients, including those with early onset hypertension, that is below age 30, who do not have other risk factors for hypertension, including obesity, metabolic syndrome, or family history. Additionally, to screen patients with resistant hypertension or individuals with sudden deterioration in blood pressure control, or in patients who present with hypertensive urgency and emergency, and those who are presenting with high probability for secondary hypertension based on strong clinical clues or for case detection. However, they do emphasize that before labeling the patient as resistant hypertension, and before starting investigation for secondary causes, we have to exclude pseudo-resistant hypertension and drug-induced hypertension. And in this, as you all know, resistant hypertension is defined as high blood pressure above 140/90 in patients who are treated with 3 or more antihypertensive medication, including diuretics, and in whom pseudo-resistant is excluded. So this is very important step before initiating workup for secondary causes. These are some of the main causes for pseudo-resistant hypertension. And you can see that the causes range from medication non-adherence to white coat effect to undertreatment to inappropriate blood pressure measurement. And these causes ranges from 30 to 60%. So it's very important to make sure that you cover these causes in order to label or before labeling the patient as resistant. And this table, it depicts some of the common medication that are associated with elevated blood pressure, which some of them are commonly used, like NSAIDs, oral contraceptive, and sympathomimetics, erythropoietin, and FEGF inhibitors, as well as steroids. So go thoroughly through the patient medication list. Now, coming to the causes of secondary hypertension, it is not among the causes of secondary hypertension, endocrine causes are not the commonest. The commonest causes of secondary hypertension is obstructive sleep apnea, CKD, and renovascular disease. Among the endocrine causes, primary hyperaldosteronism is the commonest, while FeO and Cushing constitute less than 1%. While other causes like thyroid, parathyroid, and all of them, they will be diagnosed with hypertension at the same time or even before. So from this table, the most important thing is to understand that the commonest causes of secondary hypertension is not endocrine causes. And this is very important to avoid over-investigating, and because people, when they will over-investigate unnecessarily and they ended up having negative result, then they will encounter, when they are going to encounter the patient that should be investigated, they will not investigate him. So this is very important to bear in mind. Here you can see the most common etiology of endocrine causes, including adrenaline-dependent causes and apparent melanocorticoid excess, parathyroid, pituitary, secondary hyperpara, and thyroid-dependent causes. For the sake of time, we will just focus mainly on catecholamine-related causes and primary hyperaldosteronism, and we will touch on hypercortisolism. So I will start with the first case. So this is a 21-year-old male patient who presented to the ER with occipital headache, blurred vision, and photophobia. He was found to have a high blood pressure of 198/145. He reported having similar symptoms when he have a high blood pressure reading. He reported being diagnosed with hypertension 6 months back and presented to another major facility also with hypertensive emergency. He had extensive workup there where he had negative endocrine workup, and CT angio showed normal renal arteries, aorta, and no evidence of vasculitis, and also reported normal adrenals. So he was placed on double therapy with amlodipine perindopril, which he stopped 1 month back because he felt better. His family history is negative. Medication, apart from these two antihypertensive, he is not on any medication. But social history, I found it interesting because he is final year engineer with high GPA, non-smoker. He lives in the hostel of the university, but sometimes he lives in a hotel in another city and come daily to the university. I found personally this is something weird. So you could see that his high blood pressure when he presented to the ER was very high. He was treated with antihypertensive at the emergency. He had also AKI with creatinine of 133. He was admitted for a few days, stabilized. Actually, after this, he developed hypotension. And then workup was sent, and he was given a follow-up in the clinic. In the clinic, all investigation came negative as expected, but this time he admitted the truth. Before being admitted, he consumed 20 bottles of eye drops that's called nafsolazine phenyramine ophthalmic solution. And this is contain antihistamine and discongestant. And he do that very frequently as a suicidal attempts. And he goes and lives in a hotel far away from where he studied because when he has this idea of suicidal attempts. And he's fully aware of what will happen, high blood pressure, bradycardia, and then he will develop hypertension and tachycardia. And he used to measure even his blood pressure at home when he takes this medication. So you can see he was referred to psychiatry, diagnosed with major depressive disorder with anxiety and suicidal attempts. And you could see on antihyperdepressant, his blood pressure is much better without any antihypertensive medication. So the first lesson or the first thing to learn from this case, you have to rule out pseudo-resistant and drug-induced hypertension. Moving to the second case, this is a 41-year-old male admitted with seizure. His known case of epilepsy since 2017, stopped his medication. On ER, he was found to have high blood pressure and low potassium. Admit diagnosed as hypertension 2015, but he stopped his antihypertensive for the last few months. In chart review, he was labeled as uncontrolled with compliance issue. He was on triple therapy. While being in telmisartan, his potassium was ranging from 3.6 to 3.3. His rest of the history and examination was unremarkable. So you could see that he has hypokalemia and his bicarb are in the upper part. So therefore, her primary hyperaldosteronism was suspected and aldosterone renin was sent. And you can see that renin is suppressed, aldosterone is high, and therefore aldosterone renin ratio is high. And he is suppressed normally to 1 milligram dexamethasone suppression test. So primary hyperaldosteronism, despite being a common condition, especially in patients with resistant hypertension, it is underdiagnosed. And this study showed that among, which is a population-based study, among patients who have hypertension and hypokalemia, that's mean around more than 25,000, they follow them for 2 years, and only 1.6% have been screened for primary hyperaldosteronism. The majority were not, though these patients, as per the recommendation, should be screened for BA. And this finding has been replicated in several other cohorts across the continents. So why we are concerned about primary hyperaldosteronism? Because if left untreated, it is a condition that is associated with increased cardiovascular disease and increased risk of kidney disease, as well as metabolic risk. And therefore, you need to screen for BA in the following cases. Any patient with hypertension that is resistant to 3 conventional antihypertensive drugs, any patient with hypertension and hypokalemia, whether spontaneous or diuretics induced, hypertension with a family history of early onset hypertension or cerebrovascular accident at a young age below 40, or any patient with hypertension and adrenal tumor or adrenal lesion, and controlled blood pressure with more than 4 medication, or patient with hypertension and sleep apnea, and any relative for a patient with primary hyperaldosteronism. So the approach basically starts with the detection, and then confirmation, then localization. Detection starts with aldosterone-renin ratio. However, it is better to look at these parameters individually and dissect them. So you look at the renin. If the renin is suppressed, then you look at the aldosterone level. If the aldosterone level is high, elevated above 15 nanogram per deciliter, which is highly suggestive of primary hyperaldosteronism, then this is primary hyperaldosteronism, and you can go to localization study immediately. If the patient have suppressed renin while intermediate aldosterone level, then you need a confirmation testing. While if the aldosterone is low, then BA is unlikely, but the patient still has low renin, and therefore you could treat him as low renin hypertension, and therefore you could treat him with mineralocorticoid receptor antagonist. Now, why this is the case? Because aldosterone is pulsatile. So even among the same patient, you will have different levels of aldosterone, and even among patients who have primary hyperaldosteronism, you may have sometimes normal aldosterone-renin ratio. So it's very important to dissect the parameters individually. But to be aware that there are several medications that can affect the results. If you have a patient that is highly suspected of primary hyperaldosteronism, for example, very high blood pressure with spontaneous hypokalemia, you just need to test them without changing any medication. However, most of the medication cause false negative. The medication that you need to be aware of is really beta blocker, because it can lower the renin and cause false positive. So if you ended up with a patient whom suspecting him to have primary hyperaldosteronism and you screened him while on medication, and he turned to have a false negative result, then you could start and change the medication to the medication that will not affect the result and rescreen him again. However, this will take time and you need to rescreen again. Otherwise, you could just change the medication from the beginning and screen. So the medication that you could use for the patient to prepare him for screening is verapamil, hydralazine, and doxycycline. And it doesn't need fasting or to bring the patient in another day. No, he can just come after you see him, go to the lab and do the blood test. And this is make it easily for case detection. And by this way, you don't miss the patients. Now, you have to be aware of other differential diagnoses of mineralocorticoid excess syndrome. So in case the patient have low renin and low aldosterone, just to be aware of acquired causes like hypercortisolism and licorice toxicity. Other forms, the genetic forms, are very less common, but you could consider it when you exclude the others acquired causes. In case you have a patient with high renin and high aldosterone, this is secondary hyperaldosteronism. If the patient is hypertensive, then you have to rule out renal atherosclerosis, aortic coarctation, and reninoma. If the patient is normotensive, then Gitelman and Parker's. So back to our case, because he have very high aldosterone and low renin, doesn't need any confirmatory testing. These are the confirmatory testing used in BA, a fludrocortisone suppression test, but IV saline suppression test, oral sodium suppression test, and captopril challenge test. Every center use the test that is available and can be easily done. I found oral sodium loading is very applicable and easy to apply. So we went to localization. The patient have CT, which showed 14 millimeter left nodule. And if I can show you here in this video. You could see the nodule here. Then this was followed by AVS, which was non-stimulated AVS done while he is on medication, but also he had low potassium. I want just to take a little time here because the first thing you have to do is look for what we call it selectivity index. So this is left adrenal, right adrenal, and IVC. First, you look to the cortisol level. Make sure that the cannula was properly, or the veins was properly cannulated. So you can see here that the right was properly cannulated, but the left was not properly cannulated because the ratio had to be more than 2. I mean, right to IVC or left to IVC more than 2. So you can see that the left was not cannulated. So only right was cannulated, and therefore, when you calculate aldosterone to cortisol ratio, the right side is suppressed compared to the IVC, which means that the source is the left. So even that we did not cannulate the left, we can use the suppression index on the right to conclude that the secretion was from the left. And therefore, the patient has left adrenalectomy. Post-operatively, immediately, his potassium was normal. Actually, he developed post-operative hypotension and his aldosterone was low. Follow-up in the clinic, he was off all antihypertensive and off potassium, and he is normocalemic, and you could see the drop in GFR after the adrenalectomy. Moving to the third case, this is a 30-year-old male presented with nausea, vomiting for 1 day with abdominal pain. He was found to have high blood pressure and hyperglycemia in the ER. So because of this, he had CT abdomen, which showed bilateral adrenal lesions. He had negative past medical history, but you could see that he has quite high blood pressure. He was normal height, not that much, not that tall, but also he had right thyroid swelling. There was no marfanoid picture and no mucosal neuroma. You could see the CT showed bilateral lesion, and actually the lesion in the right is lobulated, big one, while the one in the in the left is lobulated, while the one in the right is smaller. So investigation showed that the patient has catecholamine excess, and he is normocalcemic. And also because of the thyroid swelling and the bilateral lesions with a pheochromocytoma, suspected to have MIN2, so calcitonin and CA were elevated. So BBGL, as you know, are neuroendocrine tumors. They originate from the neural crest tissue. When they are in the adrenals, they are called pheochromocytoma. When they are outside the adrenal, extraadrenal paraganglioma, they are either parasympathetic or sympathetic. Usually the sympathetic one are below the diaphragm, the parasympathetic one above the diaphragm, or mainly in the head and neck. Genetic predisposition play a major role in BBGL. So when to screen for BBGL, any patient with paroxysmal sign and symptoms suggestive of catecholamine excess, any patient who have paradoxical blood pressure response to drugs or surgery or anesthesia, including beta blocker, any patient with resistant hypertension, and any patient with incidentally discovered adrenal mass, especially if they have with or without hypertension, mainly with the Housefield unit above 10, or previous diagnosis of BBGL or hereditary predisposition or syndromatic feature. And the screen is by measuring plasma free or urinary metanephrines. And usually the method is LCMS. The thing to be aware is that there are many medications that could interfere with the readings, depends either as analytic interference or pharmacodynamic interference. Analytic interference is mainly when the method applied is LC-ECD. So here, acetaminophen, labetalol, common medication can affect the result. While when it is pharmacodynamic interference with all methods, because it is related to the way of action of the medication, including antidepressant, phenoxybenzamine, monoamine oxidase inhibitor, sympathetic mimetic, and levodopa. Another thing to be aware of that if the patient tend to have mildly elevated, then you need to repeat it in a supine position at least for 20 minutes before taking a blood investigation, because there is a difference when the patient is in supine position. So back to the case. So the patient was started in doxycycline, alpha blocker, followed by beta blocker. He was prepared with taking a lot of fluid and high salt intake. Then he had bilateral adrenalectomy, where it showed bilateral pheochromocytoma with a lots of micro pheochromocytomas, multiple, which is very characteristic of MID2. Then this was followed by thyroidectomy with central neck dissection, and the pathology was medullary thyroid cancer. He had a genetic test, which showed that he has a mutation in codon 634, which placed him in the high-risk group. Final case is a 55-year-old female who had adrenal lesion discovered incidentally when she presented to the ER with chest infection, and it showed a left adrenal lesion of 3 by 2 centimeters. She reported that over the last few months, she had worsening glycemia and blood pressure control, no history of fracture or osteoporosis. As you can see, she is on 3 antihypertensive medication, and still her blood pressure is uncontrolled. And this is when I saw her in the clinic. So you can see that she has a lesion in the left with an absolute washout of 37.5. So workup was sent, and she did not suppress to 1 milligram overnight dexamethasone suppression test in 2 readings. Her aldosterone-renin ratio and plasma norepinephrine, norepinephrine were within normal, including her 24-hour urine cortisol. You could see that her morning baseline ACTH in the lower side and DHEAS in the lower side. So this patient have autonomous cortisol secretion, which is basically defined as cortisol above 50 following 1 milligram dexamethasone suppression test. And this is a quite prevalent condition, around 45 to 50% of adrenal incidentuloma. It's important because it is associated with increased prevalence and severity of hypertension compared to non-functioning lesions. Also increased risk of type 2 diabetes and cardiovascular disease, osteoporosis, and even mortality. How to approach it? This is from the European guideline. It depends on the degree of hypercortisolism and depends on the patient comorbidities. If the patient have lots of comorbidities with autonomous cortisol secretion, then it is advisable to proceed with surgery. And this is what we did with the patient who have adrenalectomy, tend to have benign adrenal adenoma. Her blood pressure now better control. Still she is on triple therapy, but at least a better control. Her glycemic control was better. She lost weight, but this was, I think, with the medication adjustment and the introduction of GLP-1 agonist. So in conclusion, a specific cause of secondary hypertension can be identified in around 5 to 10% of hypertensive patients. Before initiation of workup, make sure to rule out soda-resistant hypertension and drug substance abuse. Early diagnosis is important to institute the appropriate targeted treatment, and this will have a consequence on the patient blood pressure and antihypertensive medication pills. The most common types of secondary hypertension in adult are renal and renovascular. Among the endocrine causes, PA is the commonest, and please follow case detection testing for endocrine causes. Thank you so much, and I had the mic for you, back for you, Bidur.
Thank you very much, Dr. Raya, for these interesting cases. There are a couple of questions in the Q&A box, but it will be addressed toward the end of the 4th session. So we will move to the second presentation, hypoglycemia case. It will be presented by Dr. Hissa Ibrahim Bouharoun. She's an endocrinologist and diabetes consultant working at Sheikh Khalifa Medical Center. She's also as well neuroendocrine specialist. She had her fellowship at Royal Free Hospital London. And she has more than 20 publications in endocrine and diabetes. The floor is yours, Hassan. You can start your presentation.
Good evening, everyone. I'm glad to be today part of the team presenting one of my cases, and I will be presenting a case about hypoglycemia. Through my presentation, I'll go through the case. I will touch on view of the hypoglycemia definition, types of hypoglycemia, management, and take-home message. Actually, this case, one of the interesting cases that I saw during my training and that has been published September last year. So please feel free to access the case and to read more about it if you interested in the case during the presentation. So we got a patient who's 50 years old, a British man who presented at his wedding day with feeling unwell and confused. And his presentation was 25 years before visiting us to the clinic. At that time, his blood glucose was around 2.3 millimole per liter. And if we would like to first define the low blood glucose or hypoglycemia, there is mainly two main definitions. First one is low plasma glucose of less than 4 millimole per liter, which is equal to 72 milligram per deciliter. And the other definition is development of neuroglycopenic or autonomic symptoms in patients treated with insulin or oral hypoglycemic agent, which are reversed by caloric intake. Going back to our patient, he did mention that he had some symptoms of pins and needle sensation in his arms and tongue, confusion. He had actually fasting hypoglycemia for the last 25 years. His symptoms mainly relieved with meals, and he's taking more than 3 meals to avoid the attacks of hypoglycemia. His symptoms or episodes remain stable over years and managed with diet. If we think about the symptoms, we will think about Whipple triad classically. So fasting plasma glucose of less than 2.2 milliliter, hypoglycemia, of symptoms, administration of glucose. So all of that is presented in our patient. So classically, you will think of insulinoma. However, it's not a specific for insulinoma. So we need to think about different things. And in order to get other different the types of hypoglycemia, really two categories of hypoglycemia. We have postprandial hypoglycemia and fasting hypoglycemia. Postprandial hypoglycemia, usually we see it in patients with bariatric surgery or type 2 diabetes. Fasting hypoglycemia, we can see it in other differential diagnoses or other causes like exogenous drug use, pituitary insufficiency, liver failure, Addison disease, island cell tumor. Other main types or classification of hypoglycemia is non-diabetic and diabetic, and we can see the causes in each type. Our focus will be in the today in the fasting, actually non-diabetic hypoglycemia. If we will talk about the symptoms of hypoglycemia, usually define hypoglycemia when low C will start hormonal change, which will lead to symptoms. So at level around 68 milligram per deciliter, the glucagon will release, which will be the first hormone that will be released. Then at 66, the adrenaline and growth hormone will be released. around 57, cortisol will start to released, and this is will cause the adrenergic symptoms, actually sweating, palpitation, and feeling hungry. Then around from 50 to 46, we'll start to have the symptoms, cognitive dysfunction. At lower level, coma and seizure, and even lower than 20 death. So going back to our patient. So why did he came to us, or why he did decide to came to us after 25 years of the symptoms? Because his symptoms getting worse in the last 3 months, more severe, and he did collapse twice. So when we asked him more, we found that he get recently diagnosed with hypertension, started on amlodipine, family history of type 2 diabetes, he's non-smoker. He got a new post as a healthcare trainer, and currently he has 3 children between 12 to 23 years, all of them healthy. Okay, on examination, our gentleman, he looks generally well. His blood pressure was slightly elevated. His heart rate was regular. Weight was 69, so it's almost normal for his height. Other examined system was unremarkable. If we will think of hypoglycemia, sometimes it will be associated most of the time with obesity for a specific diagnosis or disease like insulinoma. But unfortunately, but this man actually, he was not obese. His weight was almost normal. And this is a case report actually of metastatic insulinoma, which has been presented after bariatric surgery. So the patient was obese, had bariatric surgery, then they discovered that he got insulinoma. So it's one of the presentation of insulinoma is obesity. So if we summarize or think about the case so far, we have long history of fasting hypoglycemia, Whipple triad, non-diabetic patients. So what the thing that we need to think of or the differential? Actually, there is few differential that we need to exclude or go through or think about. First is non-insulinoma pancreaticogenous hypoglycemia syndrome, and this syndrome will be presented with fasting hypoglycemia, and it's due to the hypertrophy of the beta cell. Post-gastric bypass hypoglycemia, we did just mention that mainly it will be present with postprandial hypoglycemia. Fictitious use of insulin, usually we will think about it with fasting hypoglycemia, and if there is access to the healthcare facility to be able to get insulin, and it's the same for the sulfonylurea-induced hypoglycemia. Insulin autoimmune hypoglycemia, usually they can present with also fasting hypoglycemia, but we will find antibody or other autoimmune disease. Non-island cell tumor that secretes insulin-like growth factor, this is mainly releasing of insulin growth factor type 2 can cause hypoglycemia without increase in insulin level. Noccidoblastosis, as we know, it can happen as a secondary of other causes. Also, it's hypertrophy of the beta cell, which can also cause hypoglycemia. So those are the main differential for non-diabetic hypoglycemia, if we say. If we think about our patient, he does not have a gastric bypass or bariatric surgery, so we can exclude that. He unlikely he would be able to get an other medication or access to the medication because he's not a doctor or nurse or a healthcare worker. He's a healthcare trainer, but he's not. He does not have access to the medicine or medication. So we left with the other differentials. So what you would like to do next? So for us, we did the 72-hour fasting test, and it's revealed a glucose at a glucose level of 2.9. We took the insulin level, which was 247, C-peptide above 3,000. We did 24-hour urine collection for sulfonylureas was negative, adrenal antibodies negative, and hemoglobin A1C was 36 millimole per mole, which was normal. So if we would like to interpret this result, it will be positive if the insulin level above 36, and then we can see that it's around 247. if C-peptide level more than or equal to 200, and we can see it's more than 3,000, and proinsulin more than or equal 5 picomole per liter, but we did not do it for this patient in our hospital. And we did send for adrenal antibody to check for any autoimmune disease. For completion, we did a short synactin test, cortisol stimulation test, and it was at 30 minutes, 487 nanomole per liter, which is actually at any point, if it is above 450, it will be a pass test. So it was normal. Okay, so talking about different differential of fasting or non-diabetic hypoglycemia, we need to think of those main differential. And to differentiate between them in terms of result, we will find that for insulinoma, usually the serum insulin will be high, the plasma C-peptide will be high, plasma proinsulin will be high, and those three will reflect the endogenous insulin hypersecretion. The beta-hydroxybutyrate will be low because, as we know, the insulin level will be an anti-ketogenic. It has an anti-ketogenic effect. This is for insulinoma. This is the typical or classical finding. For sulfonylurea ingestion or other medication, we'll find that serum insulin will be high, plasma C-peptide will be high, proinsulin will be high, and beta-hydroxybutyrate will be high. So it will have a similar presentation to insulinoma, as we know that sulfonylurea is secretogayic, so it will secrete insulin and will have a similar picture. But the difference that we'll find positive urine for sulfonylureas. For insulin use, we'll have serum insulin high, plasma C-peptide low, plasma proinsulin will be low, and beta-hydroxybutyrate will be low. So here the difference, we can see that with exogenous insulin use, serum insulin only will be high, but the C-peptide proinsulin, which indicate the endogenous insulin synthesis, will be low. For insulin autoimmune hypoglycemia, serum insulin will be high, plasma C-peptide will be high, plasma proinsulin will be high, and beta-hydroxybutyrate will be low, and antibodies will be high. So as we know that it will have the same picture of insulinoma, but with positive antibody. For IGF-2, as we said, the secretion of the IGF-2 will cause hypoglycemia, so serum insulin will be low, plasma C-peptide will be low, plasma proinsulin will be low, and beta-hydroxybutyrate will be low. So what you will do next after those results? Actually, will you ask more about drug history for this patient? Will you do imaging? Will you start diazoxide to release his hypoglycemic symptoms? Will you refer him to dietitian? So actually for us, we did an imaging, and actually he had an MRI scan done at his local hospital, which showed a 4.1 centimeter lesion in the body of the pancreas. Also, it showed a lesion in the liver, which was indeterminate. So after this, we decide to do a CT gallium dotatate scan at our center, and unfortunately it did not show any gallium avidity in the scan, so it does not show any tumor in the pancreas, which might indicate insulinoma. And for the education, I would like to show you here that this is a gallium scan for a positive, actually, gallium avidity for insulinoma in the pancreas. Usually it looks like the uptake will be like that. Okay. So what we at that point, we did diagnose or have a provisional diagnosis of insulinoma plus an indeterminate liver lesion, possible metastasis. According to that, we did complete our investigation. If I would like to talk about insulinoma now, just in a summary, it's the second most common hormone-secreting pancreatic duodenal neuroendocrine tumor and multiple endocrine neoplasia. And it's a neuroendocrine neoplasm found throughout the body in all organs, although they are more commonly in the lung, digestive tract, and the pancreas. It's made by cancer cell expressing markers of neuroendocrine differentiation, including chromogranin A and synaptophysin, which considered the whole tumor markers. that we usually depend on for diagnosis. Insulinoma, lifetime prevalence around 10% in adults with MEN1, and in MEN1, it's count 10% of all patients with insulinoma. The main insulinoma is typically between the size, usually between 2 to 3 centimeters, located anywhere in the pancreas. It has a similar actually prevalence in the whole pancreas, tail, body, or head. Removal of the tumor usually is a curative, and the post-operative recurrence rate of insulinoma may be higher in MEN1 than sporadic cases. Okay, if we go through some questions, is insulinoma type of cancer? Is it benign or malignant? So usually, just to answer this question, it has two answers actually. Usually, you will find that in the literature, in the books, that insulinoma is benign, and usually, if there is any metastasis, it will be considered as a malignant. But in general, all the neuroendocrine tumor, they consider the cancer cell. Can insulinoma cause diabetes? Do you think? Yes or no? Okay, so it's yes. Insulinoma actually can be a cause of diabetes if the treatment of insulinoma requires a significant amount of pancreas to be removed. What is the gold standard investigation for diagnosis? Usually it's 72-hour fasting test. This is the gold standard for hypoglycemia actually. What is the most sensitive radiological modality for localization? Is it MRI CT? Is it arterial stimulation? Is it endoscopic ultrasound or somatostatin receptor imaging gallium scan? What do you think? Actually, this is quite, it's not only one answer. Actually, the combination of CT, MRI scan, and endoscopic ultrasound can achieve almost about 100% sensitivity. Talking about gallium scan, somatostatin receptor scintigraphy, it has also a positive result only in about 50% of cases due to low density or absence of somatostatin receptor subtype 2 and 5. So if the receptor is not present in the cell itself, it will not show any gallium ability, so it will be negative. That's why it's negative in our case. Okay, so this is just to summarize the approach to patient with hypoglycemia, or if we suspect hypoglycemia. Usually, if we get the typical diagnostic criteria by fasting, 72-hour fasting test, and we did exclude other differential diagnosis. We go through the imaging. We start with ultrasound, CT, or MRI scan. If the tumor is undetected, we go through endoscopic ultrasound, somatostatin analog scintigraphy test. If that does not detect or reveal the tumor, we go into intraoperative ultrasound plus palpation. Intraoperative palpation, actually. Okay, and there is case series report that only 30% of pancreatic head insulinoma were palpable intraoperatively, in contrast to intraoperative ultrasound. So it might be more useful than palpation. Talking about imaging, I would like just to inform you that there is a newer data suggests that insulinoma highly express also glucagon-like peptide 1 receptor, and thus are labeled with a GLP-1 R agonist. 111 indotexinidine 4 scan, which has been used successfully in detection of small tumor, both pre and intraoperatively. But it's difficult to find it. We did not even find it, have it in our center. It's only available in selected center in the world. Going to question 5, what's the best medication which can control hypoglycemia? What do you think? It's diazoxide. What is the mechanism of action of diazoxide in hypoglycemia? Actually, diazoxide, it inhibits insulin release from the tumor itself. What is the type of hypoglycemia in insulinoma? We did mention that earlier. So fasting hypoglycemia is the most characteristic finding of insulinoma, reported in around 73% of patients. 20% of patients have both fasting and postprandial hypoglycemia symptoms. Okay, going back to our patient, we did have a diagnosis of insulinoma plus an indeterminate liver lesion based on the fasting test and scan. He underwent an open distal pancreatectomy, splenectomy, cholecystectomy, and liver wedge biopsy. This was an extensive procedure, actually. Post-op, the pathology find out 5 by 106.49 millimeter tumor was resected from the distal pancreas. There was no evidence of a gross invasion, abnormal lymph node, or liver metastasis. And this classified as an insulinoma according to European Neuroendocrine Tumor Society TNM stage 2006 to B, T3, N0, B1, M0. The segment 4B lesion, focal nodular hyperplasia, and negative for metastatic neuroendocrine tumor markers. So it was not a liver metastasis. And we can see here, this is the pictures for the pathology, and we can see the Ki-67 of the tumor 4%. So the Ki-67 is, as you know, it's the proliferation marker, and it's 4% considered as grade 2. So our patient, post-operative course was complicated by a low output pancreatic fistula which rapidly resolved. His random blood glucose level post-surgery varied between 6.5 to 10.5 millimole per liter. So he was doing well. 6 months post-surgery, he remains well, eating normally. He had no further hypoglycemia episode, which was great. Then we did send for genetics test for MEN1, and it was negative. He remained under annual follow-up with imaging. Okay, so talking to that, insulinoma survivors should be followed up to 3, 6, 12-month interval post-operatively and subsequently annually, especially patients with malignant disease or a MEN1 associated tumor due to higher risk of relapse. So they have a lifelong follow-up. Treatment option in insulinoma, usually surgical removal. For metastatic insulinoma causing hypoglycemia can be treated surgically for palliation only, just to relieve the symptoms of hypoglycemia. Hypoglycemia caused by unlocated metastatic insulinoma can be controlled with diazoxide or somatostatin analog, but it's less effective than diazoxide. To summarize the surgical procedure in insulinoma, we have a procedure called inoculation. Inoculation, usually it's a parenchyma preserving procedure. You remove the tumor and with safety margin around 1 centimeter. And this will prevent any fistulas, and also it's good for the small tumor. Distal pancreatectomy, another procedure that we keep it for the large lesion or for malignant. What is the latest treatment option in insulinoma? We should just touch upon the different other treatment option of insulinoma. We have an inhibitor of the mTOR kinase, everolimus. It's hypoglycemic episode in patients with inoperable or malignant insulinoma. They can try mTOR kinase inhibitor, but it can be effective up to 6.5 months. Tyrosine kinase inhibitor agents, sunitinib malate, have also been tested, presenting relative success and may have future role in treatment of insulinoma. CD-guided radiofrequency ablation also has been successfully used in the treatment of insulinoma of an elder patient with hypoglycemia. Ultrasound-guided ablation with ethanol, also another way for treatment option. Peptide receptor radionuclide therapy, PRRT, also is another procedure, but they should have expression of the somatostatin receptor to be able to uptake the therapy. So from this case, the take-home message is, first, if we did realize that BMI 24, so the patient was not obese, so not every insulinoma patient will present with obesity, which was unusual. Usually the insulinoma patient, they will be obese. The other thing is in the literature, when I did published case, I did review all the literature regarding the sizes of insulinoma. Usually it's between 1.5 with a range between 0.1 to 7 centimeter largest. And we can see that this is, for this case, it's a quite large size. and it might actually the large size because of the long history without any intervention. And the interesting also about this case is that the symptoms was managed only by diet for 25 years, and he was doing well. And also we do realize that it's long history with a large tumor without metastasis. So a lot of interesting things in this case. So I hope you find it interesting and useful. I would like to invite you to read more about the case if you are interested to know more about it in details. Thank you for listening. If you have any question, I'm very happy to answer it.
Thank you, Dr. Hissa, for this fascinating and wonderful overview of insulinoma. So any question, you have any question for Dr. Hissa, you can post it in the Q&A box and to be addressed later toward the fourth session. So now we move to the third presentation. What is the acute anti-hypercalcemic medication that will be presented by Dr. Asma, who's a consultant working at endocrine consultant working at Tawam Hospital. She's as well adjunct assistant professor in the College of Medicine at UE University. Her field of interest is Dr. Hissa in endocrine are osteoporosis, bone metabolism, obesity, and lipid disorders. So Dr. Asma, kindly unmute yourself and share your presentation.
Thank you, Dr. Abdur, for the kind introduction. I really enjoyed my colleagues' presentation. Dr. Raya and Dr. Hissa, they did great. My presentation is a bit simpler, and I'm going to talk today about hypercalcemia. So what medication can bring calcium levels back to balance? I don't have any disclosure, and my objectives for tonight is going to be talking about the definition, briefly definition and causes of hypercalcemia, evaluation necessary to determine the nature of hypercalcemia, and the treatment options for acute hypercalcemia. Hypercalcemia defined as a level of calcium beyond the normal level, and it's classified based on the calcium level into three types, either mild hypercalcemia when the calcium between 2.5 to 2.99, moderate between 3 to 3.49, and severe if the patient is having calcium level equal or above 3.5. When the patient confirmed to have hypercalcemia, it's very important to look at the PTH and know if the PTH level is suppressed or inappropriately normal or high. So when you're called for hypercalcemia, you need to confirm it. You need to repeat another sample of calcium, serum calcium, and to look at the corrected calcium level, corrected based on the albumin level. If the calcium, corrected calcium confirmed to be high twice, then you need to measure the PTH. Based on the PTH, you need to go further in your evaluation. So if the PTH is low, then you need to consider the non-PTH mediated causes of hypercalcemia. And if the patient is having high or normal PTH, then the next step is to measure the 24 hours urine calcium. And based on the urine calcium also, you will go further in your evaluation. So if the patient is having low urine calcium, then familial calciuric hypercalcemia is going to be high on your differential, and you need to go further in your investigation by ordering a genetic testing if you have an access to genetic test. If the patient is having high calcium, high PTH, and high urine calcium, then the differential is going to be either primary or tertiary hyperparathyroidism. And based on the CKD, you will differentiate between them. For the non-PTH mediated hypercalcemia, so now you confirm that the patient is having high calcium twice, you found that the PTH is suppressed, then you need to go further in your evaluation by ordering vitamin D and vitamin 125 dihydroxyvitamin D and PTH-related peptide. If the PTH-related peptide is high, then most likely the patient is having hypercalcemia of malignancy. And if the patient is having the 125 dihydroxyvitamin D high, then you should consider the granulomatous disease or lymphoma. And if the vitamin D is high, then most likely the patient is having vitamin D intoxication. And if the all of the above mentioned tests are normal and there is no abnormality, then you need to look at other differentials like multiple myeloma, medication-induced hypercalcemia, hyperthyroidism, milk alkali syndrome, or immobilization. What we need to know that most common causes of hypercalcemia, so more than 90% of the cases are usually either primary hyperpara or malignancy-induced hypercalcemia, and that's most common reason for admission in the hospital. So during the coming few minutes, we will discuss a couple of cases, and they're going to be polls, and I wish that you participate in the answering the questions. So case 1, 53-year-old male patients with hypertension and CKD presents with headache, fatigue, and thirsty. The patient is on hydrochlorothiazide, lisinopril, calcium carb. You did the labs and you found that the calcium corrected is a 3.25 millimole per liter. And this is considered high. PTH is undetectable. Serum creatinine is 250, while the patient baseline is 115, and serum bicarb is 36. So what is the diagnosis? Please put your answer. It's going to be a question for case 1. Okay, can we look at the results, please? Any results coming? Okay, so most of you chose that the patient's reason for hypercalcemia is the 40% chose a combo between calcium carbonate and calcium carbonate induced hypercalcemia. So it's not wrong, but this is, if you're looking at the patient bicarb level, so the patient was having high bicarb, and the diagnosis in this case is milk alkali syndrome. And I think we're missing many cases with milk alkali syndrome. And based on applications, it is the third most common causes of hypercalcemia among patients' hypercalcemia. And the main risk factors for milk alkali syndrome is older patients and those susceptible to volume depletion, those who are on diuretics, patients who has CKD, and patients on medication that might reduce the eGFR, like AC inhibitor or AR or NSAIDs. So if you notice, our patient from the history, 53, patient already has CKD, and on the medication, the patient's on diuretics and lisinopril. And the patient is on calcium carb. So the main reason what put the patients on milk alkali syndrome is the loading with calcium carbonate. So the calcium carbonate, it is causing the alkalization of the blood, and the patient is loaded with the high amount of calcium that will put them at a risk of having a hypercalcemia. And when they're having a high amount of calcium carbonate, the suppression of calcitriol production will lag behind. So we don't have a suppression of calcium of the calcitriol production. So they're still going to have a good calcitriol production along with the high ingestion of calcium carbonate, which will cause alkalization also of their blood, and that would cause hypercalcemia. When they're having hypercalcemia per se would have multiple effects on their system. So it's going to cause vasoconstriction of the nephrons, which is going to reduce the eGFR, going to cause activation of the calcium sensor receptor, inhibiting the sodium-potassium chloride, and that will lead to natriuresis. Again, that's also will put the patients to worsening their hypercalcemia. The hypercalcemia would block the ADH-dependent water reabsorption in the collecting duct. And again, that will increase the calcium and the concentration and the extracellular space. The calcium-induced osmotic diuresis also will worsen the calcium level, and the hypercalcemia is going to cause a stimulation of the renal tubular absorption of bicarbonate. So now we know that our patient is having milk alkali syndrome. So what is the treatment for such cases? The treatment usually is to stop, if you can, stop the calcium carbonate or reduce the dose. And based on the recommendation, should never be above 1,500 milligram per day. It would be also better to switch the calcium carbonate to other form of calcium, like calcium citrate, to avoid absorbable alkali. If the patient is having no heart failure and no CKD, vigorous IV hydration with isotonic normal saline, calciuresis with IV loop diuretics is very helpful after, for sure, after good hydration with the normal saline. You should avoid giving a bisphosphonate for such patient. And the patient, those patients will have high risk to have a transient hypocalcemia. When they're having hypercalcemia, PTH would be suppressed. And when you're correcting with IV hydration and loop diuretics, the calcium level will be suppressed immediately, but it's going to take time for PTH to correct to the level of the calcium. And if you're going to get the bisphosphonate, that will worsen the hypocalcemia and might put the patients at risk of persistent or refractory hypocalcemia. Okay, so we're going to the second case. Second case is about 19-year-old male patient who's admitted with abdominal pain, nausea, vomiting, fatigue, and palpitation. Patient had a spinal cord injury 6 weeks prior to presentation, and an ER, the blood test showed that the patient is having calcium-corrected 3, phosphate was high, PTH undetectable, PTH-related peptide is normal, vitamin D is normal, 125 dihydroxy vitamin D is low, and the 24-hour urine calcium was high. So what is the diagnosis? Well, hyperthyroidism, immobilization, dehydration, sepsis, adrenal insufficiency. Please put your answers. We'll have it only for 30 seconds. Then please show the results of the poll. Okay, so 40% immobilization. And yes, this is the correct answer. So immobilization. Patient had spinal cord injury 6 weeks back. And this is basically the immobilization related to hypercalcemia when it mostly occurs within 4 to 6 weeks after immobilization. And the risk factor for immobilization, I think we're over diagnosing immobilization hypercalcemia in the hospital. After reading a lot about immobilization hypercalcemia, it is not for patients who only for a short period of time or chronically immobilized, mainly for those who had acute immobilization with shutdown of their muscles activity or simulation to the bone. Those who are more susceptible, usually children or adolescents, and especially males, those with renal impairment and increased bone turnover. And that's when they're an adolescent or children, they're having a high bone turnover during growing bones. It's usually a diagnosis of exclusion. And what is the idea behind it or the mechanism behind it? When the patient is having spinal cord injury, their muscle stops stimulating the osteoblast or osteoclast activity. So we know that we're having usually a ratio between OPG and Rankel Leiden. The osteoblast cells producing OPG and Rankel. When we're having OPG ratio is higher than the rank, it's going to stop the ligation, the binding between Rankel and Rankel ligand receptors on the pre-osteoclast cells. When we're stopping that, that will prevent the osteoclast activity and will inhibit the bone resorption. So what would happen when we don't have the muscle stimulation, muscle stimulation of the bone, that will suppress the osteoblast production of the OPG and will increase the Rankel production with the integration between Rankel and their receptors, and would lead to stimulation of the osteoclast and increase the bone resorption. And that will, as a consequence, will increase the calcium efflux from the bone, causing hypercalciuria and PTH suppression. So hypercalcemia happens when the efflux of the calcium from the bone excess the capacity of the renal excretion. And this is the mechanism behind the immobilization-related hypercalcemia. So how we would treat patients with immobilization-related hypercalcemia? Basically, we need to hydrate them vigorously. Most of them, they don't have heart failure, they don't have kidney injury, so you can give a high volume of hydration. Loop diuretics would help also and enhance the calcium excretion. If the patient is having severe hypercalcemia or they're having symptomatic neurological symptoms like altered sensorium, the calcitonin can be started. Those patients, because they're having higher osteoclast activity, would really benefit from getting a bisphosphonate and denosumab, especially on the longer run when they're going to start to continue to have a high osteoclast activity and suppress the osteoblast activity. And that bisphosphonate or denosumab, the anti-resorptive medication, would reduce the osteoclast activity. So moving to case 3, this is a 32-year-old African woman, presents with lethargy, polyuria, and polydipsia. Past medical history, she was complaining of joint pain and chronic cough. The labs showed that her calcium corrected is high, phosphate is high, PTH undetectable, 24 hours urine calcium is high, and 125 dihydroxyvitamin D is high. Just X-ray showed that she's having bilateral lymphadenopathy. So what is the diagnosis? TB, lymphoma, sarcoidosis, Paget disease, or diabetes insipidus? Answer, please. Okay, can we look at the results, please? Yes, so most of you got it right. 41% answered the sarcoidosis. Actually, you had many hints in the cases leading you to the answer. So she's African woman, she's having joint pain, chronic cough, and she's having bilateral hilar lymphadenopathy. Okay, so this is granulomatous or lymphomatous hypercalcemia. 10 to 20% of patients with sarcoidosis would present with hypercalcemia. And this is basically because those patients is having high volume of macrophages. And we know that the macrophages possess the 1-alpha hydroxylase activity. And that would lead to increase the production of 125 dihydroxyvitamin D, and having a very high level of 125 vitamin D would increase the intestinal absorption of calcium and phosphate. And as you notice that here, calcium and phosphate is high, and urinary calcium excretion was also high. So how we would treat such patient? She's having high calcium. She's symptomatic, but not severely symptomatic. So mainly we need, that's going to be a long-term treatment, and those patients would live with their sarcoidosis for life. So we need to teach them how they need to deal with themselves on daily basis. They need to have dietary modification, avoid high calcium intake, oxalate intake. They should avoid the sun exposure, heavily sun exposure. Patients with pulmonary involvement of sarcoidosis, or if they have a high calcium level, severe or even moderate calcium level, they can be started in a glucocorticoid steroid treatment. So for resistant cases, there is many publication about the role also of ketoconazole as a treatment for patients with sarcoidosis resistant to steroid treatment. And also infliximab, anti-tumor necrosis factor, have been tried on such cases for refractory hypercalcemia, refractory to steroid treatment, and showed very good results. And the alternative treatment, if we don't have an access to ketoconazole or infliximab, bisphosphonate and anti-malarial treatment can be used as a treatment for hypercalcemia, sarcoidosis-induced hypercalcemia, and resistant cases to steroid. So case number 4. 27-year-old female patient admitted with lethargy, headache, abdominal pain, and vomiting. She's known to have type 1 DM. On exam, she's tachycardic and hypotensive. Lab showed that she's having high calcium corrected. PTH is undetectable. Random blood sugar is 160. Bicarb is 16. What is the diagnosis? Does she have hyperthyroidism, adrenal insufficiency, euglycemic DKA, sepsis, or vitamin D intoxication? Would love to see your answers here. I think it might be a tricky one. Okay, most of you got it right. 37% answered adrenal insufficiency. And the hint here, this patient is having already autoimmune disease. She's having type 1 diabetes. She's coming with symptoms of adrenal insufficiency, headache, abdominal pain, lethargy, and vomiting. She's tachycardic and hypotensive. If you're thinking about DKA, she's euglycemic. It's going to bicarb is low. It could be adrenal insufficiency or euglycemic DKA. Taken into consideration that now we're talking about the hypercalcemia here, it might be adrenal insufficiency. So I brought this case because I need to bring your attention that there is adrenal insufficiency induced hypercalcemia. It is considered as a rare cause of hypercalcemia, but it's there, and we need to consider it when we see such patients in the ER. So hypercalcemia could be due to a couple of causes. There is an article published in the Journal of Endocrine Society that talking about the causes of hypercalcemia in such patients. It could be due to increase the sclerostin, and we know that sclerostin is increasing bone resorption, and that would lead to high calcium level. Increase the 1-alpha hydroxylase activity in those patients. Volume contraction because of the dehydration. Increase proximal tubular calcium reabsorption with the adrenal insufficiency, and increase there also the hypothesis about increase the calcium binding to protein during the adrenal insufficiency. And the last thing, it might be due to thyroid hormone effect on bones, which is going to be stimulated during the adrenal insufficiency. So how we treat the patients who has a hypercalcemia, adrenal insufficiency induced hypercalcemia. So IV hydration is important. This patient is having adrenal insufficiency with hypotension, so we need really to treat vigorously the patients with volume expansion. Always I need to mention that it's isotonic normal saline. We need to give the patient a stress dose of a steroid, and it should be followed by a physiologic dose of a steroid. In severe cases, when the patient is having either, as I mentioned before, altered sensorium, or the patient is having very high level of the calcium, more than 3.5, the calcitonin can be started to bridge the first 2 to 3 days till the steroids takes its effect on the calcium. So the last case, this is a 38-year-old woman who was found to have hypercalcemia on general workup. History of diffuse muscle aches and nephrolithiasis. She's not on any medication. Family history is unremarkable. Blood pressure was 132/78 and heart rate is 74. Labs showed that her calcium level is 3, creatinine is 57. This is normal. Magnesium is normal, phosphate is slightly low, and PTH is 9. So what is the diagnosis? Primary hyperpara, secondary hyperpara, tertiary hyperpara, or familial hypocalciuric hypercalcemia? I think easy one. Okay, can we look at the results? Yes, 58% of you got it right. So tertiary I already mentioned that the patient's creatinine is normal. So tertiary is not an option. Secondary hyperpara, we know that we're talking about hypercalcemia. Secondary hyperpara occurs when the patient is having hypocalcemia. Then the familial hypocalciuric hypercalcemia or primary, that's going to be the two options. But here the patient is already has a nephrolithiasis and she's symptomatic. So that goes more toward the primary hyperpara because familial usually are asymptomatic. Okay, so few things about the primary hyperparathyroidism. It's the most common cause, one of the most common causes of hypercalcemia. We have types either hypercalcemic hyperpara or normocalcemic hyperparathyroidism. Differential diagnosis, as I mentioned, familial hypocalciuric hypercalcemia. And to differentiate, we need to do the 24 hours urine calcium. We need to also to do urinary calcium excretion and vitamin D level to check if we need to replete them, especially those with the primary hyperpara would have high bone resorption, and that would affect the quality of the bone. So you need to replete them later on during the course of the treatment. You also need to do EGFR to look at the criteria to proceed with the management for such patient, and DEXA scan to look at the bone mass density. If you confirm that this is a primary hyperpara, you would need to go for localization study. So what is the treatment for such patient with primary hyperpara? So our patient is young, she's 30 plus, and she's symptomatic. She has already nephrolithiasis. So surgical option is basically the option for young, less than 50 years of age, patient who had already established kidney impairment, if their AGFR is less than 60, or the patient is having very high urine, 24 hours urine calcium excretion more than 400 milligrams per day, or the patient is having nephrolithiasis. So our patient, by age, she fit. By if you're looking at the renal, she's having nephrolithiasis. If we're looking at also the calcium level, if the patient is having more than 0.25 millimole per liter increment and the level of the upper normal level of the calcium, that's an indication. And our patient, her calcium is it was a 3. That's mean a 0.5 more than the upper limit of normal. So our patient is fit for surgical treatment. So if the patient agreed and she's a good candidate for surgical, take the patients for send the patients for parathyroidectomy. If she's mildly symptomatic and there is no increase and no severe hypercalcemia and no neurological symptoms, severe neurological symptoms, just give a good hydration and send for surgery. If the patient is not a good surgical candidate, or the patient is refusing the surgery, or the patient and she's symptomatic or has severe hypercalcemia, then the medical treatment would be an option for such patients. And you need to start on cinacalcet, the calcium sensing receptor agonist, to increase the sensation to the level of the calcium and the extra cellular level and suppress the PTH. And here cinacalcet is rather than bisphosphonate because we need to suppress the PTH level. So I'm done with my cases. Only a couple of slides about the general management. So general management of hypercalcemia basically depends on the degree of hypercalcemia, the rate of rising, is it chronic or acute? If it's acute, this is also what's going to need an urgent management, presence or absence of clinical symptoms, and the underlying causes of hypercalcemia. Remember that volume repletion with saline is an essential element of the treatment and care of such patients. And the 4 main strategies for lowering the calcium is going to be basically decrease the bone resorption, decrease the intestinal calcium absorption, increase the urinary calcium excretion, and remove the excess calcium through dialysis if the patient is having severe hypercalcemia and with a kidney injury. Finally, degree of the calcium and the treatment. So if the patient is having mild hypercalcemia, no active treatment needed. You just need to ask the patient to avoid factors that aggravate the hypercalcemia, stop any offending drugs like calcium, multivitamins, vitamin D, lithium, hydrochlorothiazide, and advise your patients for a good hydration. If the patient is having moderate level of hypercalcemia and the patient is asymptomatic or mildly symptomatic with a chronic hypercalcemia, then no immediate or urgent management treatment is needed, and you just treat the patients with good hydration and monitor the calcium level. And if the patient is having acute hypercalcemia and with neurological symptoms like a change in the sensorium, then you would treat the patients, even with the moderate, you need to treat them with as a severe hypercalcemia and give them a good IV hydration, start the calcitonin till the bisphosphonate effect kicks. And you need also to start either bisphosphonate or denosumab and think about the underlying causes and treat them accordingly. Again, severe would need the full treatment as in patients with a symptomatic, severely symptomatic or acutely symptomatic moderate hypercalcemia. So IV hydration, calcitonin, anti-resorptive medication, and treatment of underlying causes. And if the patient is not responding, you need to send them for dialysis, hemodialysis, and that would be the safest and the fastest way how to correct their hypercalcemia. And usually how we're doing it by decreasing the calcium level in dialysate, and the normal level is used in the dialysate is 1.25 to 1.3. So they're using a lower level, less than 1, to correct the hypercalcemia. By this, I'm coming to the end of my presentation, and these are my references. Thank you for listening. And Mike, going back to my colleague, Dr. Badur. Thank you.
Thank you very much, Dr. Asma, for those interesting cases and fascinating review. So we move to the fourth talk, skills-related talk. It's about unleashing the power of ChatGPT, which is a common talk nowadays. It will be presented by Mr. Bakhit Bishtawi. He's a specialist senior librarian who works at Medical Library of Dubai Health Authority. And he's also an editorial administrator of Dubai Medical Journal. Mr. Bakhit, you can share your presentation.
Thank you, Dr. Borod, Dr. Badur. Assalamu alaikum all. Let me share my presentation. Okay, my name is Bakhit Bishtawi. I'm working in Dubai Health Authority. This is my WhatsApp, my Twitter. I just want to clarify that today I will not talk about advanced technology. I will not talk about reports, something like this. Instead, my discussion will be just a tool, about a tool which is available to anyone, regardless the age or education. This tool today called ChatGPT, and it's one of many other tools, looks the same, and it's a powerful way to interact with computers using the natural language. Whether you are a student, a professional, regardless of your background or experience, ChatGPT can answer your questions, solve problems, or just have a conversation. My session today is something like highlight an introduction to ChatGPT, how it works, and what can be used for. I will go at the end of the session for
Mr. Bakhit,
yes.
kindly if you can share the PowerPoint with the audience.
Okay. It's okay, fine now.
Yes, we can see the presentation now.
Okay, good. I think I present this for then. as I mentioned, my session today is just an introduction about ChatGPT, how it works, how you can ask ChatGPT, how you can cite, and this is important, by the way, ChatGPT, and we will have 2 live demo on 2 examples about ChatGPT. The word ChatGPT stands for Generative Pre-trained Transformer, and actually it's a large language model developed by a company named OpenAI. Open Artificial Intelligence means that this artificial intelligence programming is available now, open access, and it's based on a transformer architecture, pre-trained on a large corpus of text. This is very important, and designed to generate human-like responses to natural language inputs. When you want to talk or deal with ChatGPT, use your normal language, and you can. And ChatGPT, by the way, can respond in Arabic, English, and many languages. An important note that ChatGPT is not connecting to the internet, or in another way, not searching the internet. Simply, when you ask ChatGPT, ChatGPT will use the pre-trained knowledge and answer you. ChatGPT will not go and search Google or there and come back to you. It does not search the internet or other external sources for answers. Simply, it looks like if you are talking with a human, but it's a machine. And when you ask somebody, how old are you? That person will answer, for example, 22. He or she will not go to the internet and search for the answer. They answer from their mind. This is the same for ChatGPT, and this is very important to keep in mind. It's a tool that can understand and respond to human language. Simply to benefit from, and I urge everybody, by the way, I can see around 1,000 participants today to go and from today and create an account, because sooner or later, this OpenAI, this artificial intelligence will be part of our daily life. You can easily go to this website, openai.com or chat.openai.com, and create your account. These are the main 2, or see the biggest 2 places for artificial intelligence. There is many other, let us say, artificial intelligence. I will not mention today, but these are nowadays trending. You can sign in later, you can create the account, you can do everything. Still, OpenAI is not available on the mobile, but at the same time, other companies create something looks like ChatGPT. I will let you see. This is an example of Pocket AI, and you can see here when you download this Pocket AI, you can see automatically give you these bullets that you can ask Chat to tell you a story, to solve you a problem, to write you a poem, by the way, to a science question, write me an essay, even tell me a joke, write me an email, give me a recipe, write me a poem, and many other things available in this Pocket AI in your mobile. If you want to benefit from asking ChatGPT, better to usually when you navigate to ChatGPT to type or speak. Speak, by the way, I tried many times. It's very powerful and very accurate. You can talk using the mic directly, and ChatGPT will start typing the question. You can even edit. Then always be clear and use your natural language, and provide as much information as you can. Always think simple and ask whatever you want, and you will see how ChatGPT will answer you. Sometimes ChatGPT will give you part of the answer. You can ask GPT, please elaborate, explain more, continue, and so on. And you will find how the interaction happened between you and the chat GPT. For citing ChatGPT, in text citation, you can just use ChatGPT and the year, or you can use this formula. Author, creator, date created, updated, and the version, name of the AI generator's response to the question or the topic you gave to ChatGPT, and then the URL and the date access. This is an example. The author or the creator of what you are asking GPT is ChatGPT itself or the company, the Open AI, because you are talking to a mind, to a brain, but a machine one. Version 3, then ChatGPT responds to questions to ask. This is, we will try this question later. I really want to ask the consultant on a diagnostic leukemia patient and the access date, for example, today, and the website is chat.openai.com. The good thing, if you are using a reference manager like RefWorks, ProSite, EndNote, Mendeley, etc., nowadays all these reference managers already aware of the new citation of ChatGPT topics. Still, this might change in the future because there is still debate who is the owner of the question, who is the owner of the answer. All these things still talking about and not finalized. I will go now live for two things. The first one, I will ask GPT about this one, and also I will ask GPT to summarize an article, and this one it will, you will see how quickly ChatGPT will summarize any article you want. Okay, let me go for this question. And by the way, this is a real question. This is the interface of ChatGPT. You might get more or less, because it depends if you are a subscriber or you are using the beta version, you are using version 3 or more. This is my screen. Again, this is a correct question we received, and the relative, the patient, want to meet the consultant and ask the consultant about a diagnosed leukemia patient. Okay, and here is the answers coming quickly by GPT. You can look at the quality, you can look at how anybody can prepare a list of questions, meet you as a consultant, whether oncology, cancer, or maybe diabetic. So here I can ask okay, now 20 questions. I can prepare, anybody can prepare a list of questions and come to you in your clinic as a physician, and imagine I can even at any time ask ChatGPT to stop or regenerate the question. Now more questions are coming. Not only that, I can, for example, ask GPT to translate these questions to me in the language I want. For example, I can go for Arabic, okay, and please translate in Arabic or into Arabic. And now all the questions I received in English, I can translate them into Arabic, French, any language, and go and meet the consultant and ask about that case. If ChatGPT stopped in this, I can ask ChatGPT in, for example, in Arabic, أكمل الإجابة, or continue, or something like this. I can easily copy paste all what's shown here by, for example, just select all. This is one way. Here, for example, I can say أكمل. أكمل means complete, okay? Okay. 15, 16, and so on. My experience so far with ChatGPT, I'm using it in my work to answer questions, to get professional emails, and it's really very nice. I'm not sure for you how you can benefit from, but it's now available anywhere, anytime, and everyone can access and use it. Let me go for the second. I will stop, for example, asking ChatGPT to stop, and I will ask ChatGPT to summarize this. I will go back to English language, and I think fourth language. And I will ask, please summarize this article. This article is available in this link. I will. Okay, I will try again. Still saying, I apologize. I cannot summarize this article because I refuse to go to external links. Also, I tried this afternoon, and they did actually, ChatGPT did summarize it for me. That's why you are dealing with a brain, a machine. Maybe at that time, I don't know what happened, answer me and summarize for me this article, and at the same time, summarize it in English, in Arabic, and everything was going fine. But this time, still apologize for any confusion caused, and so on. Okay, thank you. It's just a quick presentation, and my aim is actually to raise this, let us say, trending nowadays, will not say issue, but a powerful tool, ChatGPT, to be aware of and prepare yourself for that. Thank you for listening.
Thank you very much, Mr. Bakhit, for this talk, elegant talk. the chat GPT field is going in very exciting and direction. It's very furious. So I would invite all the speakers kindly to join the Q&A session. So we'll be going through the questions of the audience. So Dr. Hassa, Dr. Raya, Mr. Bakhit, kindly if you can join the Q&A session. Okay.
I can't start my video. Please allow me.
Okay, so do we have Raya on board?
Yes, I am.
Okay, so let's go through the questions by the audience. So there's
I think I answered some questions.
some questions you've been directly answered by you, Ryan.
But there is a question, 2 questions. I found them interesting. One of them is by Umar Mustafa. If you allow me, I can read them.
Yes, sure. Go ahead, Raya.
He mentioned, we know that most endocrine emergencies happen during pregnancy, labor, and old people. So what are the recommendations and advices that should be given to such a group of patients to avoid such emergency? I'm not sure if you mean endocrine hypertension emergency, Umar. In general, endocrine causes of hypertension during pregnancy is not that common, actually rare. We may encounter a pheochromocytoma in a pregnancy or BA in a pregnancy once in our practice or nil. So I don't think it is common in terms of endocrine causes of emergency. However, saying that, there is a link with the second question, which is saying, what is the management of non-primary hyperaldosteronism in a young female on aldactone who becomes pregnant? So in general, patient with BA, female, definitely you will try to manage their BA before pregnancy. If it is localized, then surgery. If the patient gets pregnant and she is known to have BA before, this is either direct to, it was bilateral, that's mean not localizing, or familiar, or it was just diagnosed during pregnancy. Now, the management would be with the most common antihypertensive and potassium supplement. If it didn't work and still the patient need more, you can use elebrenone because it is class B in a pregnancy compared to aldactone, which cannot be used. If it's still not controlled with all medication or elebrenone or everything, then may consider, if the patient have a localized disease, surgery during pregnancy. But I assume that these patients have non-localized or bilateral disease or familial causes, and therefore will be treated medically. Whether during breastfeeding, the same breastfeeding, also elebrenone. In regards again to Umar a question, for example, pheochromocytoma in the past in pregnancy was managed surgically, but now it is successfully in different series, case series are managed medically. So phenixabenzamine can be used in treatment, but labor has to be prepared in advance with the gynae, obstetric, and anesthesia, and prepare the medication just in case needed, especially with the increased intracranial, intra-abdominal pressure during labor. Inshallah, hopefully I can give another talk about specifically endocrine management of endocrine hypertension, pregnancy, and labor in the future, inshallah.
Okay, thank you, Raya. I'll move to the second question to Dr. Asma. There is a question for you, Asma, like when to dialyze, what calcium levels do you advise for dialysis?
Does the question about what's the calcium in dialysate, or so and the dialysate should be less than 1, but what is the indication to send the patients? Usually patients with persistent hypercalcemia not responding to medical treatment would go for severe hypercalcemia not responding to medical treatment will go for dialysis. And that would really correct it within a couple of hours.
Within a couple of hours. Any value, any cutoff point that you would advise him to consider if it did not improve?
I usually, if the patients remain and severe, it's above It depends what unit they're using, 3.5 and above. Our patient is having or 14 milligram per deciliter. And I mean, you should also bear in mind that the patient should be really symptomatic at that time. And they need just to reduce the calcium and dialysate during the dialysis. And we know that some of the patients might even not, most of them, they would respond. Very rarely they would not respond, and they would need also IV phosphate to be taken during.
Usually, Dr. Asma, I think it would be malignancy cases that the severe hypercalcemia would persist rather than the benign pathologies.
Yes, I mean, usually the humoral malignant hypercalcemia is really, first of all, it's going to be, the degree is usually very high, severe, and they're going to have like 16 or 18, and the millimole is going to be having 5 or 6. They're going to have acutely symptomatic, severely symptomatic, the patients, and they're going to have really resistant to treatment because the hypercalcemia process is really actively going on. And it depends, mostly they're having a solid tumor as an underlying causes. So for such patients, if we're going back to how we treat them, we need really to hit them hard with everything, vigorous hydration. After giving them vigorous hydration, we might start diuretics. Then at the same time, we're starting calcitonin with the bisphosphonate or denosumab based on the, if they're having CKD or not. If they're not responding during the first 48 hours, or if the patient's clinical case deteriorated during this time, we need to send them for dialysis.
So basically, until they are completely exhausted from all conservative and pharmacological therapies, to consider the dialysis.
Yes,
okay.
Right.
I have another question for Dr. Hassa. Do metastatic insulinoma cause hyperglycemia if the primary tumor from the pancreas have been removed?
Yeah, actually, interesting question. Even if it is metastatic, if we have metastatic insulinoma, it means that we have insulinoma cell in the metastatic organ. So even if we remove the primary tumor, we might get hypoglycemia if the metastases remain. So yeah, it can.
So the presence of insulinoma, even extrapancreatic, will still be causing hypoglycemia.
Yeah.
Okay, excellent. Let's move with questions for Mr. Bakhid. Is ChatGPT free? Is the application of ChatGPT is free of cost with this such amazing artificial intelligence that is providing, that can provide person?
So far, the beta version of ChatGPT is open and free, but they started a subscription-based module. I'm not sure for how long this will go, but both the free and the subscribed version are available nowadays.
Dr. Badur, would you mind letting me ask Dr. Bakhid a question regarding ChatGPT? I know that the data stored in ChatGPT is only till up to 2021. And if you're going to ask the ChatGPT any question about anything beyond 21, is going to answer that as an AI machine. I can't predict the future. So this is the, lacking, that's mean ChatGPT really lacking behind Google in terms that it is not updated to what's happening recently. What is your take on this?
Yeah, thank you for the comment. Yes, at the beginning, ChatGPT was answering in this way that the data stored there up to 2021. But comparison with Google, we cannot compare. Google is a different, let us say, application. ChatGPT is a different one. So both are totally different. ChatGPT is a machine brain, but Google is just a search engine. Nowadays, by the way, you are not seeing this message anymore that ChatGPT mentioned that up to 2021, because I think it's generative and learner machine one time, maybe it will go beyond the time we are in. We are with.
I don't know, maybe you have the subscribe one, because the free one,
Yes.
I still 2 days back, I asked, for example, who won the World Cup 2022? And they gave me the same answer. We cannot predict the future.
Yes, I have the subscribed one. Yeah, correct.
Maybe with the subscribe they're having, but as far as I know, it is only stored till 2021.
Yeah, the beta version is V3, version 4 still not free. Version 4 is not free. Maybe that's the reason. Dr. Thuraya, there is a question from, sorry, Dr. Budur, there is a question from Thuraya. Can I answer it?
Yes, go ahead,
Thuraya mentioned that she's afraid that she might become over-dependent on ChatGPT. I understand. And she said also that she might lose her soft search and skills. My answer actually, look at the ChatGPT from the other side. Maybe ChatGPT will shape and give us more knowledge and more skills in this life. So, and for me, I'm looking at the other way, from the other way, that it will help me.
In fact, there are a lot of questions posted in the Q&A, but we have 5 minutes, so I'll select the questions that is not repeated. There's a question to Dr. Raya, if which one is best to be done for testing for primary ELDO, whether it is erect or supine position.
Okay. So when the patient comes to you in the clinic, the patient already wake up and moved around for at least 2 hours till they came to the clinic. Then you just send them to the lab, sit on a seat, sitting position 5 to 15 minutes, and draw blood. No supine, no standing, no walking for 2 hours and come back, nothing of that. Make it simple so your screening will increase. And it is the recommendation as well.
Yeah, that's more simple for the patients. There's a question for Dr. Hassa, how to differentiate between a postprandial hypoglycemia in type 2 and insulinoma-induced hypoglycemia.
Yep.
Maybe you can provide with a short answer, Dr. Hassan.
Yeah, sure. Just simply for hypoglycemia and diabetes or type 2 diabetes, it's mainly will be postprandial, but for insulinoma, the classic presentation will be fasting hypoglycemia. But it can also be presented in some patients with postprandial.
Is it common to have insulinoma in diabetic patients?
No,
or
it's not
frequent, how frequent to have such diagnosis in diabetes?
Yeah, usually they can have diabetes as a complication of pancreatectomy after the surgical treatment, but not the.
It's rare to have diabetes with underlying insulinoma. Yeah.
There is, I think, case report, but it's very rare.
Okay. So what is common is common. I will move to if PTH question posted by Dr. Abdulrazak. If PTH level was high, what is what is the role of calcium and what quantity should be administered? I'm not sure I understood the questions. Probably there's some spelling. If you can, Abdulrazak, rewrite the questions. Probably there's some spelling mistake. I couldn't read it. Another questions by, I think we have 2 more minutes and then we have to move on. For Dr. Asma, how would you differentiate the effect of that hypercalcemia is from PTH, or this is a PTH related protein?
Okay, so PTH and PTH related, mostly they're having the same effect, except by vitamin D is vitamin 125 dihydroxy is gonna be normal or low when the patient is having PTH related peptide. effect. And if the patient is having PTH, hypercalcemia, the 125 dihydroxy is going to be high. So basically, this is the difference in terms of the effect of the vitamin D level. The rest of the effect almost the same.
So I need vitamin D. For the rest of questions, I would kindly ask the speakers to answer on the Q&A box because we're running out of time and we have to move on to the severe session that will be given by Dr. Ahmed. So kindly
allow me to ask Mr. Bakhit a question, very quick one.
Yes, go ahead, Raya, and then we have to move to the next session.
Just one question. I tried to use ChatGPT.
I know it's very interesting, the ChatGPT, Mr. Bakhit.
Provide me with the references. Then I copied the references and tried to open them. Either they are something unrelated to the topic or they don't open. And I tried several ones.
Yeah, actually,
from their sources.
Yeah, actually, many people faced such things with ChatGPT. As I mentioned from the beginning, it was released, I think, starting this year with a beta trial version. The new version is different. And I want to say something here. ChatGPT is just a product from a big company, OpenAI. And it's mainly for, let us say, chatting. The powerful of OpenAI is something still we did not reach. There is a question there, by the way, for can ChatGPT help in clinical decisions? ChatGPT itself may not, but OpenAI, yes. I hope I answered your question.
Thank you so much.
Thank you.
Thank you, Mr. Bakhit. Thank you to all the speakers and thank you to the audience and thanks to their participation. Kindly, speakers, you have still time to answer the questions privately for the audience, the Q&A box. So we'll move to the last presentation. It's about harnessing the value of glycemic control in holistic management of diabetes. It will be presented by Dr. Fath Rahman Ahmed. He's a consultant physician endocrinologist working at Ibrahim bin Hamad Ubaidullah Hospital in Ras Al Khaimah. The floor is yours, Dr. Ahmed. Kindly unmute yourself and share your presentation.
Good evening, everyone. Can you see the slides now? Hello?
Yes, Dr. Ahmed, we can see your slides.
Yeah, very good, very good. Thank you. Thank you very much for inviting me for this webinar, and thank you for the kind introduction. I'm going to talk a little bit different. Everyone was talking about endocrine this evening. My talk is going to be about diabetes, and I'm going to be mainly concentrating on early glycemic control. So these are my disclosure. So as we all know, and we have all seen this slide, it's very common. It's in every diabetes meeting you will see it. So diabetes is a global pandemic. The numbers are increasing. This is a big burden to health systems. And you can see like the diabetes is expected to be a big burden because the numbers are expected to increase. So in North America, there is 51 million people living with diabetes. The number is expected to go up to 63 million, and that is 24% increment. In Europe, it's going to increase by 13%. In Southeast Asia, the number is expected by 2045 to increase by 68%. But more important, in our area, MENA region, the numbers are 73 million. By 2045, the number is expected to go up to 136 million, and that is 87% increase, which is going to be like, it's a big increment, it's going to be a big burden on the health system, and we have to be ready and prepared for it. So the numbers are increasing, and diabetes is also a very common cause of death. Worldwide, it contributes to 12% of deaths. And the numbers differ where you live. For example, in Europe, it is responsible of 8% of deaths. In North America and Canada, 18%. In South America, 8%. And when we come to our region, MENA, the number is really worrying. It's 25%. It goes 25% of cause of death for diabetes. So our numbers are always high compared with the rest of the world. So we are very lucky that we are in a time where we got a lot of options to treat type 2 diabetes. So if you go back 20 years ago, you got metformin, sulfonylurea, and insulin. But now we have too many options when we are treating type 2 diabetes. Despite that, good glycemic control, or the target of less than 7, which is recommended by most of the clinical practice guidelines, is still not well achieved. So if you look at this data from the US public health analysis, so if you look at the number between 1999 and 2002, it was 44, and the number was increasing in 2006. And then when it comes to 2010, you can see that the good glycemic control, less than 7% A1C achievement, is actually declining. Despite that, there is more concentration of treating diabetes. You got more treatment options. But despite that, the number of people who are achieving the standard A1C less than 7 is actually, the number is reducing, which is worrying. It was 57, now it's down to 50%. So there's an alarm. There's an issue here that as healthcare professional, there is an issue somewhere. We have to rectify this. And again, when we look at our area as well, the problem is even more pronounced. You can see even there is a big variation. So the achievement of A1C less than 7, it's between 11 and 41%. So it's less than 50% with big variation. If you look at the number here on the left side, you can see data from different countries. So there is variation, and there is also very small number, less than 50% achieving A1C less than 7. So there is an issue in our diabetes management. So as we all know this, if diabetes is not well controlled, then the patient are going to be prone to long-term complications. Microvascular complications are actually unique to diabetes. So diabetic retinopathy is the leading cause of blindness in working age adults. Nephropathy is the leading cause of end-stage renal disease and kidney failure. Neuropathy is the leading cause of non-traumatic lower limb amputation. Macrovascular complications are more common in individuals with diabetes, but there are other factors contributing to it. So if you have diabetes, stroke, if your diabetes is not controlled, there is 200 to 400 increase in stroke and cerebrovascular mortality. And heart disease, we know that is the leading cause of this of diabetes is heart disease, 50 to 80%. And peripheral vascular disease, it leads to painful peripheral neuropathy and lower limb amputation. So if you look at this data, and which was done between 2006 and 2010, and the mean follow-up for 8 to 9 years, about 9 years. So long-term complications are delayed if we control the diabetes when we are looking at hemoglobin A1C, and now we have other metrics. So from this data, with everyone higher hemoglobin A1C, independent of the diabetes status, this is associated with 18% greater risk of MI in both women and men. So if you have high A1C, there is 1% higher, you get 18% risk of getting an MI. And this is for both males and females. And again, if you look at the all-cause mortality, even 1% A1C higher is associated with 22% risk of all-cause mortality, myocardial infarction, and ischemic stroke. So reducing the hemoglobin A1C is very beneficial for our patient. We have to concentrate on that from the beginning. So this is actually a very interesting data. It's done by Professor Rory Holman, who is the third man in Diabetes UK, and that is from New England in 2008. So they looked at about 110,000 people with type 2 diabetes. They have A1C more than 7 for after the 1 year of diagnosis. And then one group, they started intensification of treatment immediately. And the other group, they started the intensification after 6 months. So it's just 6 months difference. And then they followed the patient for 5 years. And they found that there was a statistically significant increased risk of MI and a statistically significant increased risk of cardiovascular events. So early intensification is very important. Delays or clinical inertia, even 6 months delay is associated with significant increased risk of MI and cardiovascular event. So when we are seeing our patient, we have to make sure that we are concentrating on diabetes control from the start. And this is another study, which is actually very interesting. So they looked at 2 groups. So there is one group, they started intensification from the beginning, and the other group, they started the intensification at 12 months. And then they followed them for 5 years. So if you look at the curve, you look at the graph, you can see, of course, the intensification from the beginning, they achieved hemoglobin A1C around 6 months, less than 7. The other group, they didn't achieve it. But when we started the intensification late, you can see the graph continues the same way. Like those who have intensification early, they continue to have good control. And those who have delayed intensification, they still did not achieve A1C less than 7. And when they followed them for 5 years, they found that the group who have delayed intensification for 1 year, they have increased risk of MI by 67%, stroke by 51%, heart failure by 64%, and cardiovascular event by 62%. So this is a strong evidence, a very clear evidence that intensification from the beginning is associated with preventing complication, and delayed or clinical inertia is associated with increased cardiovascular event. So again, when we are treating diabetes, we are always trying to address other cardiovascular risk factors. So this is actually a data from the New England 2018. Again, they looked at the relationship between cardiovascular risk factor and cardiovascular event. And from this data, they found that hemoglobin A1C is the strongest predictor of acute MI and stroke. It's even followed by blood pressure and by LDL cholesterol. So I think we are at the stage now where in the new guidelines, they are all concentrating on cardiovascular prevention, concentrating on starting medications, cardiovascular benefit. But again, we should not ignore getting good glycemic control from the beginning, because this is a leading factor of and a strong predictor for cardiovascular events. And this is actually another evidence for the importance of getting good glycemic control and A1C reduction. And the evidence is coming from the cardiovascular event outcome trials, which was done on a lot of medication, like the new ones, Sustain for semaglutide, Pioneer for oral semaglutide, Rewind for dulaglutide, Leader for liraglutide, and Imbrec for empagliflozin, Declare-Timi for DABA, Canvas for canagliflozin. So they looked at the data, and if you see there, I mean, some of them, they are definitely for the GLP-1 and SGLT2 inhibitor. Most of the studies showed cardiovascular benefit. But if you look at the data here, when they put these studies together, they looked at they compare the A1C with the cardiovascular event. And you can see that the lower hemoglobin, even on these studies where they clearly show cardiovascular benefit, but there is more benefit if you have low hemoglobin A1C. And again, this is a meta-analysis done on 10 randomized control trial, 92,000 patients, done by the American Diabetes Association. And again, it showed the same thing, that if one A1C reduction, 1% A1C reduction is associated with 30% risk reduction of MACE outcome. And we see this on the guidelines. So any type 2 diabetes, lifestyle, and when we start medication now, there is two important things. So the first important thing is that when patients they have cardiovascular disease or cardiovascular risk or kidney disease or heart failure, your drug of choice is SGLT2 inhibitor and GLP-1 analog, regardless of hemoglobin A1C and regardless of metformin initiation. But again, when we start the treatment, we have to make sure that from the beginning to avoid clinical inertia, and we need to make sure that from the beginning we intensify the treatment to achieve hemoglobin A1C, as I showed from previous slide, that it is associated with reduction in cardiovascular events. So when we are talking about type 2 diabetes, we have to always go back and refer to the UK-BDS. So this is from UBDS 1998, which is the original one, and then the follow-up, which was done by Rory Holman in 2008. So this is, despite that, when the UK-BDS was designed, there were not too many medications, there were very minimal options. What is very clear that after 44 years follow-up, that glycemic control is associated with the reduction of microvascular. That was really very clear from UK-BDS and DCCT. Microvascular complications are reduced by reduction in A1C. And even macrovascular in the UK-BDS, it showed that there is reduction in myocardial infarction for obese patients who are treated with metformin. And there's also reduction in all-cause mortality. So this is just, I'm going to mention about one drug. The guideline has to go as it is. Now the priority is for cardiovascular event or cardiovascular risk or heart failure and chronic kidney disease. So if that is the case, then your priority and your agent of choice is SGLT2 inhibitor and DDB and GLP-1 analog with proven cardiovascular benefit. This has to be started first. But when we start this medication, again, we have to make sure that we are controlling the diabetes. So if needed, from the beginning, we can start on 2 agents. Intensification shouldn't be delayed, as I showed from other agents. So now there is a lot of talk and there is very clear evidence. There is a lot of benefit from SGLT, GLP-1 analogs. But our old folks are still there. They are not completely taken out of the guideline. They are not completely out of use. The sulfonylurea are still in use. Yes, their efficacy in A1C reduction is very high. Yes, their main problem is hypoglycemia and weight gain. They don't have cardiovascular benefit, but they don't have risk as well. They are neutral in terms of cardiovascular. They are safe anyway to use them in cardiovascular. And progression of chronic kidney disease, they don't have any effect on that. They are neutral. They are oral agent and they are also low cost. So if you look at the sulfonylurea, they're not the same actually. We got the old generation sulfonylurea like glimepiride and glibenclamide, glipizide. These the old generation of sulfonylurea are the ones who are associated with more hypoglycemia, more weight gain. The new generation of sulfonylurea, they have less. They still have they cause hypoglycemia. They still cause weight gain, but it is less if you compare it with the other ones, the old generations. So as I mentioned, they are very efficient in A1C reduction. So this is a study where the target was to achieve intense or glycemic control A1C less than 6.5. So they randomize one group to control other group. They give the intensive group, they give them sulfonylurea, the other one is standard of care, and it's very clear that the sulfonylurea group achieve A1C less than 6.5 with statistically significant results. And this is also another CBRD study which was done, and the outcome of the study was to achieve A1C less than 7%, and this was comparing gliclazide and sitagliptin. So they found that 35% of patients who are on gliclazide achieve A1C less than 7% compared with sitagliptin. So gliclazide is superior, it's very efficient in A1C reduction. Again, this is what I just mentioned. So if you look at the risk of hypoglycemia, you can see the glibenclamide, glipizide, glimepiride, nitoclamide, their risk of hypoglycemia is very high. But when it comes to gliclazide, you can see it's just coming to the midline there. There is risk, but it is less. So my conclusion and take-home message from this talk, that diabetes is a global pandemic and it's spiraling, especially in the MENA region. Tight glycemic control is associated with reduction in long-term complication. Despite wide range of treatment options, control is not achieved in a high percentage of patients. Early intensification and avoiding clinical inertia is the key in achieving glycemic target and delaying long-term complications. Thank you.
Thank you very much, Dr. Ahmed, for this presentation. And you have shown very clearly in your presentation and in your graphs that early initiation of an intensification of glycemic control have the glycemic legacy to prevent the long-term complications. I would re-emphasize this message to our colleagues all over to avoid the clinical inertia and intensification for the glycemic management. So if your time allows, I would we have two questions for our colleagues. Someone is asking what HbA1c level should trigger me to start a combo medication rather than a single oral hypoglycemic agent? Any HbA1c level to trigger using from the beginning a dual agent or a triple agent?
I think this is a very good. So when we start treatment for type 2 diabetes, so there's two things. First thing is lifestyle changes, and the second thing is the medication. So if I have a patient in front of me who I'm 100% sure that he's going to comply with lifestyle changes, he's going to lose weight, he's going to follow strict diet, he's going to exercise. I will expect a lot of benefit from this in terms of A1C reduction. But as I showed from the beginning, that even when, and even from the verified study where they did metformin and metformin vildagliptin, again, when you intensify from the beginning, when you give more than one agent from the beginning, this is associated with legacy effect. Even in the future, when you do the intensification after 6 months or after 1 year, you might achieve A1C reduction, but the intensification from the beginning is associated with longer duration maintenance of A1C reduction. I don't think it is just an A1C level, but from there is a lot of things. I mean, the lifestyle plus, but if somebody's got a high A1C, I would start the dual agent from the beginning because it's associated with long-term maintenance of low hemoglobin A1C and long-term reduction in complications, as I showed from some of the studies.
Okay, so this is again like not to worry from the intensification and avoid the clinical inertia. One question about the glycoside, like some medications recently, the pharmaceutical companies posted that it might cause retinopathy deterioration. Is glycoside, is there any reports associated with glycoside can cause retinopathy deterioration?
Okay, so the drug which is associated with retinopathy deterioration is semaglutide, the injectable semaglutide. So that's why we have to do the retinal screening, we have to avoid it in active retinopathy. Glycoside per se is not associated with there is no data to confirm that's associated with increased retinopathy deterioration and retinopathy. But the like rapid improvement in A1C is associated with deterioration and retinopathy, which can be associated with any drug.
Yeah, okay. It's not drug per se.
Yeah, it's not drug per se. And even that is one of the explanation probably for the retinopathy, because for the deterioration retinopathy with semaglutide, it's not very clear why it happened, because other GLP-1 is not shown and there is no receptor on the eye for the GLP-1s. So because semaglutide is very potent in A1C reduction, there was a theory about the explanation for the deterioration retinopathy because of rapid improvement in glycemic control. But the glycoside is safe with retinopathy.
Okay, that's very good and reassuring. There's another question for you, Dr. Ahmed. Is there a relation between high sugar diet and risk factors? Because some theories say that if diet is zero from carbs, can prevent a stroke, like carbs-free diet.
Can prevent a stroke. I mean, low carb diet is very good for weight reduction. If somebody is obese, one of the good option for treatment of obesity is low carbohydrate diet. So if you low carbohydrate diet, you are still taking some carbohydrate. It's not like keto diet or zero carbohydrate diet where your metabolism is going to be completely shift to ketosis and your brain is going to use ketone rather than glucose all the time. I have not heard about any like link between low carb diet and stroke. I think it would be even beneficial because it leads to weight reduction, and weight reduction is associated with improvement or reduction in
metabolic profile,
cardiovascular mortality as well.
Yeah, very good. Great. Dr. Ahmed, there's another question. Is that does really metformin help in losing weight?
Metformin is neutral or it is associated with very minimal. So I wouldn't say it is associated with significant weight reduction. Probably 1 or 2 kilos, it can happen, but we can say it's weight neutral. It's not like
almost weight neutral. I think we are also running out of time, but thank you very much, Dr. Ahmed. It was very nice discussion and nice overview. Thanks for your time and thanks for being part of us today. Thank you so much, and thank you for all the audience who have took part in the presentation today. And thank you for all the speakers and for the MCI group for the technical background support. Again, just to remind you, you're following this session, you'll be receiving a survey. Kindly fill it and you'll be receiving your certificate that is DHA accredited within 4 weeks. Again, for this session, you can watch it again on the EDS YouTube channel or on demand on the EDS Institute website. Our next coming symposium will be the thyroid, and it will be on 26th July. And finally, I would like to thank Servier for sponsoring our academic activity for tonight. Thank you again, and have a good night.